Good afternoon. My name is Patricia Williams. I am currently the Vice President of Quality at Methodist Hospital Northeast in San Antonio, Texas. I have been Vice President of Quality at Northeast for a little over a year. I was prior Vice President of Quality at Methodist Hospital Texan for a couple of years. Background in patient safety, quality, as well as formerly an emergency nurse, and was also the Associate Director of Emergency Services over at Methodist Hospital. Thank you so much for the opportunity to present our work regarding the implementation of standard work and its effects on our hospital-acquired infections. And I would love to hear from you if you have any additional questions. I know my information will be shared afterwards. So to get started, a little bit of background on our facility. In 2022, we did have an increase in catheter-associated urinary tract infections, as well as CLABSI, so the central line-associated bloodstream infections from the prior year. In partnership with our amazing administration team, as well as our wonderful nursing partners and operations partners across the facility, we were able to take a broad overview, a broad general look at our practices across the facility and partner to improve outcomes overall. So this is just a snapshot of what we're about to delve into. So as you know, healthcare is definitely a very fast-paced and dynamic field, and there are many variables that go into everyday operations that can impact patients so very much. What we found is that without having mapped out structured processes for our everyday operations, sometimes those details can be, those small details that lead up to big events can be missed or overlooked, and then can definitely impact patients overall. So in May of 2022, our quality teams partnered with our nursing teams. So our VPQ, of course, and then our CNO partnered closely together to take a look at our overall practices across the facility. We wanted to see where we were in a current state. So we embarked upon a gap analysis to figure out what processes do we have very well mapped out, and where do we still need some help? Do we have variation from unit to unit in regards to hand hygiene? Do we have variation from unit to unit in our facility regarding central line care and Foley catheter care? Also, what we wanted to study was what are our conversations around de-escalating invasive lines? So are we talking about removing lines as quickly as possible, de-escalating invasive lines as quickly as possible? What we found when we did our study is that we did have quite a bit of variability from department to department throughout our facility. So one of the things that we wanted to focus on initially was hand hygiene. And I know it sounds incredibly basic, but hand hygiene is one of the single most effective things you can do to reduce the spread of transmissible infection. So it's definitely a great place to start. While we did have a platform in place to monitor hand hygiene, which is called HandWatch, it's a great little electronic platform. We did not necessarily have the specifications outlined for how many hand hygiene observations each department should do, and then did it also include operations partners as well as our nursing partners. So early on, we mapped out our expectations to say each nursing unit will enter 200 hand hygiene observations every single month to take a look at those practices on a more of a broad scale. So night shift observations were required, day shift observations were required, and then we also had requirements for our operations partners to log their hand hygiene as well. So radiology partners are so very critical. Inpatient safety, our lab partners are so very critical to patient safety. EVS team members, dietary, all our teams across the facility make such a huge impact on patient care and safety in general. We wanted to make sure this was a very comprehensive program. So partnering with our chief nursing officer and our chief operating officer, we were able to launch the expectations. And this is something that we reported out not only every single month to all of our teams, but in our daily huddles as well on Mondays and Thursdays. We wanted to make sure that everybody was aware of how many hand hygiene observations we are still in need of, as well as hand hygiene compliance. and some of the biggest opportunities that we're noticing. One of the things also that went along with hand hygiene was making sure that our observers are comfortable giving that hand hygiene feedback for missed opportunities in the moment. So we definitely want to make sure that, yes, we're logging those observations, but at the same time, giving that constructive feedback and sharing the whys behind why it's so very important to make sure we're capturing hand hygiene at every single appropriate moment. Something else that we were looking into is how we care for our Foley catheters and how we care for our central lines. So our division partners came out with a wonderful tool, a wonderful audit tool for bundles for central lines as well as our Foley catheters. Each bundle audit, for example, for central lines discusses, it starts with, is there an active indication for this line? And initially, when we started rolling out the bundle audits, we had so many more opportunities for lines that did not have active indications than we do now. So we've definitely seen a great improvement in that particular space. So along with starting off with, do we have an active indication? We talk about the site, how it appears. Is there any redness? Is there any sign of infection? Do we have a clear dressing? Do we have a CHG pad? And then are we performing those CHG baths? So several different components go into those bundles for our central lines, and then for Foley catheters. It always starts with, is there an active indication for the Foley catheter? What is the active indication for the Foley catheter? As well as pericare, is it being completed? Are there any dependent loops? Is the bag dated? And is the bag below the level of the bladder? So there are several key indicators that we're looking at every single time we are performing a bundle audit. And so the expectation that we rolled out across the facility, once again, with our nursing partners and our chief nursing officer, is that every single invasive line, Foley catheter, and then for the central lines, every central line gets audited once every shift. It was a little bit of a lift at first, but explaining the whys that go into the bundle audits was so very key to ensure our team members knew that it wasn't just another box to be checked, but hey, this is so very important that we are laying eyes on these lines every single day. And most importantly, can we de-escalate it? We know that if there is no central line, there's no CLABSI. We know that if there's no Foley catheter, there's no CAUTI. So starting with the very basic, does this line have an active indication, is so very powerful. So it was very important to make sure that our bedside team members were actively engaged with bundle audits, and it's something that's very easily measured on our dashboard that our division team members have created. So our directors also do central line audits as well as Foley catheter audits, just for a little bit of inter-rater reliability, and then to help support our senior leaders in partnership with our infection preventionists also audit lines as well. So it's very important that all of our team members see that the entire facility is engaged in having all eyes on lines and making sure that we're removing invasive lines that are no longer indicated, and always making sure that they are impeccable if they are still indwelling. Another thing that we implemented were twice a day line de-escalation conversations. Having that additional visibility on what lines are in place for what patients and the why that's associated with it was so very helpful. We layered this into a meeting that already was occurring. It's a throughput conversation, and part of throughput is making sure we can de-escalate those lines so patients are able to move around a little bit more freely, move towards health, and then progress to home a little bit more quickly. So we layered in the charge nurse report out on invasive lines of anything that is at risk. So anything that is at risk is anything of concern coming in from another outside facility, of course, but anything that is 2 days and greater indwelling. So we always want to make sure that we have eyes on all of these lines and reducing them as quickly as possible. Another great reason to have those conversations twice a day. In the morning, we talk about what lines we will be de-escalating, and then our afternoon conversation is more of a follow-up to share what we did de-escalate, if there were any barriers to de-escalation, and what the future plans are for invasive lines. So we studied this for several months throughout 2022, and not only with the implementation of a robust hand hygiene program, the implementation of the bundle audits, every line, every single shift, with the additional layers of leadership and then senior leadership audits. Along with those 2-a-day line de-escalation conversations, not only did our line days decrease significantly for both our central lines as well as our indwelling urinary catheters, but we also became infection-free, CLABSI and CAUTI-free for the last 6 months of 2022, and we've had some significant results also in 2023. So our journey towards zero harm still continues, and this was just a wonderful project that we were able to work in partnership with our nursing team members as well as our operational team members. And we look forward to more success and less patient harm.